Welcome to Gutsy Talks. I'm Rachel Larson, your host, naturopath and nutritionist, and I'm here to have real, honest conversations that can help you heal your gut, calm your mind, and fall back in love with food. Together with leading health experts, we'll dive into all things gut health and explore the deep connections between your gut and overall well-being, so you can feel empowered to take control of your health and live your best life. If you love all things gut health, follow me for more on Instagram at rachel.larson or head to rachellarson.com.au. Now, let's get into today's episode. Today's guest is someone who truly needs no introduction in the world of gut health. Dr. Allison Siebecker, often called the Queen of SIBO. A naturopathic physician, award-winning author, clinician, and teacher, Dr. Siebecker has been specializing in SIBO since 2010. Dedicating her entire practice to helping people overcome this complex condition, she also teaches SIBO at a medical university level and was honored with a Lifetime Achievement Award by the Gastro ANP in 2021 for her pioneering work. Dr. Siebecker's mission is clear: to share cutting-edge information about SIBO, empower people in their health journey, and inspire healing. Today, she's here to deep dive into the often overlooked key to gut health, motility, and why it plays such a crucial role in both the cause and treatment of SIBO. So welcome to the show, Dr. Siebecker.
Thank you. Thank you for the lovely introduction.
I was just saying off record that it's a bit of a fangirl moment, and you are absolutely like one of the biggest names in the world of SIBO, and to have you here just feels like a bit of a pinch me moment for a gut health nerd like myself. It's been a hot minute, or I should say a long time, that I've known of you, and to be actually having this conversation with you, not only, makes me feel amazing, but anyone listening, they're in for such a treat. So just thank you so much for taking the time to, chat to me.
Thank you. Thank you so much.
So for anyone who doesn't know who you are, obviously you are the Queen of SIBO and you have earned that name in every way that you could earn it. But what is your journey to working in this field of SIBO?
Well, like so many people, I had digestive troubles. It's a sort of a standard story. Like people, they wind up with their own troubles and then they're trying to find answers. And that's what it was for me. I was trying to find answers, and it was complicated, and it was like a long road. But eventually, after graduating medical school, that's when I found out about SIBO. And I because before that, what I had would have just been called IBS, irritable bowel syndrome, which there wasn't many good solutions for, and not very good information. But when you then frame it as SIBO, because a majority of IBS is actually due to SIBO, that's then when there was some real help. And I got so excited, and it just like this lit this fire under me, really just to help, because I had suffered for a very long time and I got very quick relief. It wasn't 100% relief, but I had a lot of pain, and my pain went away within 24 hours.
Wow.
And when I first found out about some treatment options, and actually it was from diet that happened. So something fairly simple. And so I just, like, my heart just went out to anyone like myself who I wanted to just help people shorten the period of suffering. It's like, we might, there are cases of SIBO that are incurable, but it still doesn't mean you can't get 80% better in your symptoms, And so anyway, I just delved into it and put my entire focus on it and practiced only for that, and just filled file cabinets full of research papers, and now dedicate myself. I practice, but then dedicated myself mostly to education on it, just to get the word out.
Of course. I mean, and like, thank you for turning your pain into what you have, which is this, as you said, like this fire and this drive to not only help patients, but to, spread the word. Because that's the thing, is it sometimes feels like it's this elephant in the room when it comes to gut issues, but it still feels like it's a secret, or it's just not spoken about with as many people. And it's like, come on, like there's tons of research behind it. Like this should be something that is as common that we're talking about as IBS, but it's just not there yet.
Yeah. And I think part of that is we only got ICD-10 codes, like official diagnostic codes, internationally for SIBO about a year and a half ago. So that, I think once that came into establishment, now we can make the proper headway. It's like, oh, it's real.
Yes. Yes, because there is still that thing of like it's just very naturopathic and it's very like, a bit made up. But again, like will absolutely be a fantastic stepping stone for people to be like, there is something that we need to take seriously that's happening to a lot of our patients.
Yep.
So I really wanted to take this conversation into a part of SIBO which I know is still, SIBO is misunderstood. So this is also misunderstood, and that's the world of motility. Now, and I know that it has got a lot to do with both the cause and the treatment of SIBO. But for people who are like, what is motility and how is it linked to SIBO and what do we mean? What is it? What are we talking about when we're talking about motility?
I mean, generally, motility is in relation to this is movement inside the gastrointestinal tract, and there's different sets of movements for each organ,
Mm.
the stomach, the small intestine, the large intestine, and the one that really relates to SIBO primarily is in the small intestine because it's a primarily small intestine situation. And really here we're talking about the migrating motor complex, which we call the MMC for short, because it's a long name. And it's this type of motility that it's not the movement of like what everybody knows about peristalsis.
Yep.
And I mean, and we could consider this a form of peristalsis, but primarily peristalsis refers to the food movement when we have the food in us. And that is a very different sort of a movement than the migrating motor complex. What the migrating motor complex is it happens after food and in between meals and in fasting, and it's called the housekeeper wave. And it sweeps debris and bacteria also on a daily basis whenever we're not eating down into the large intestine out of the small intestine. So it's kind of like a broom, and that's why it's called a housekeeper. And it also could be thought of sort of like washing the dishes after you eat, because after we finish that, then this comes to clean up.
Mm.
And this is the body's number one protection against getting SIBO, because the body has this mechanism that physically moves bacteria out of the small intestine every day. So at night when we're sleeping and in between meals if we're not snacking. And so this is a form of motility. And this is considered to be the main, I guess you could say, physiologic underlying cause of SIBO is a deficiency of this motility, this particular motility, this migrating motor complex.
That makes so much sense. And I think people listening to this are going to be like, wait, do I have a motility issue? Do we know how many people with SIBO likely have a motility as an underlying, I guess, root cause for their issue?
We don't have like one particular number, but what we know is it's the majority. It's considered to be the main real reason of why people have SIBO is this migrating motor complex has become deficient. And there are a whole lot of potential causes to what could make it become deficient. But just as a comparison, the other sort of main reason, because there's all sorts of reasons, but like the main chunks of reasons would be some sort of anatomy is altered in the small intestine. So we would call that a structural issue. There's like something physically, like let's say a tumor or an adhesion, or there's something physically maybe blocking the flow of that bacteria out of the small intestine with the migrating motor complex. But that would be secondary as a cause. The migrating motor complex. So it's like most people. And just to clarify something right away is that what can be really confusing is the most common presentation of SIBO is to have diarrhea. I mean, we haven't talked about this yet, but there's different types of SIBO, but they're related to bowel movement patterns, and people can have constipation, diarrhea, or a mixture of the two. Sometimes they have normal bowels. That's less common. But diarrhea is probably the most common out of those three patterns. And so it gets confusing to people because they think, well, because what I'm describing is slow small intestine motility. And yet the most common pattern that goes with that is diarrhea. So a key thing to know is that there's, as I mentioned, there's separate motilities in each organ. And so you could actually have fast motility in the large intestine while having slow motility in the small intestine. So just as an example, gastroparesis is a condition of slow stomach emptying. And we see people all the time that have gastroparesis, but diarrhea. So their
Yeah.
stomach is hardly moving, but they have fast motility somewhere else. So
Wow.
that's just something important to know.
Oh, it's hugely important because again, people are then trying to think about how does this relate to my symptoms? And I guess what you're explaining is that the symptoms don't always correlate to what's happening internally. In that, again, you assume, if I've got diarrhea, I surely can't have an issue with my small intestinal motility. And you're saying, no, you absolutely can. And that's not a great way to measure the internal motility of, your inner workings. Can we please talk about, I guess, now if people are thinking about, all right, well, what symptoms do I need to be looking out for if I think I have a motility issue? Are there like red flag symptoms that kind of suggest I do have a migrating motor complex issue?
Well, I think the most common manifestation of slow MMC, slow small intestinal motility, is SIBO.
Yeah.
Right. And so just briefly, what are those symptoms? It's constipation, diarrhea, or a mixture of the two, abdominal bloating, abdominal pain or discomfort. And then there could be other symptoms too: acid reflux, nausea, a feeling that food sits in the stomach and won't go down. That's sort of a classic gastroparesis symptom, which can accompany this.
Yeah.
There can be mood symptoms like anxiety is really common. Brain fog's very common. Depression, less so, but still can occur. Fatigue. There can be excessive belching and flatulence. Sometimes there's not.
Yeah.
And if we were just, so those are the symptoms of SIBO, but if we were just saying, let's say somebody had slow migrating motor complex and it hasn't yet quite developed into SIBO, like what would those symptoms be?
Mm.
It would be abdominal bloating, because the idea here would be there's a normal amount of gas that's created. I mean, let's hope one wouldn't be creating too much gas in their small intestine
Yeah.
if they didn't have an overgrowth of bacteria, but
Yeah.
still there would be a small amount. And it's possible, like even just from swallowed air,
Yes.
it's possible that that would then just stay stuck in the small intestine because it's called retained gas,
Mm.
because the movement isn't there to sweep, as well as the bacteria sweep the gas out. So bloating, also nausea. Nausea can be caused by gas back pressure. If there is gas sitting there in the small intestine, it can sort of like push up.
Yeah.
And then there could also be acid reflux. So those are sort of the symptoms I would think of that might be occurring even if you don't have SIBO, like maybe
Yeah.
before getting SIBO, just from slow migrating motor complex. But for the main part, we just think SIBO,
Yeah.
like that's what it is.
And there will be, I think when this podcast goes live, there will be a episode on SIBO. So for anyone who is like, all right, well, how do we test for SIBO and, how do we confirm SIBO? That is what you need to go to because, not to digress, but I guess to explain that is that, we do need to test for SIBO just to confirm that is there because while it can look like a duck, sound like a duck, walk like a duck, we also want to know that it is a duck and it's not in fact something else that we're working with. So,
And this
yeah.
is such an important point because
Yeah.
also those symptoms that we just described that are SIBO symptoms,
Yeah.
which they're the same symptoms as IBS, they're also the same symptoms as about 35 other conditions. And that's called our differential diagnosis medically. And it's huge for SIBO and IBS. And so there have been studies done showing that you can't diagnose it by symptoms because how can you tell it's the one of 35 things?
100%.
You can't. You have to test. Yeah.
Absolutely. Yeah. I mean, my motto, and I think a lot of people in this space is test, not guess. We just have to know what we're working with. And, there even still be SIBO alongside other conditions. So even if there is a SIBO positive test, then that doesn't actually mean that we've ruled out the other 34 conditions. There still may warrant, additional exploration if that's, if that fits that person's picture. So testing super important. With the migrating motor complex, how does it get disrupted? How does it become dysfunctional? What are the causes or risk factors for that happening?
Yeah. So basically, how it works is we need to have both smooth muscle to be able to make those motions, and we need to be able to have nerves working well to get the signal from the brain and from within the small intestine to create the movements.
Mm.
So that it's dependent upon muscles and nerves being healthy and functioning to make these contractions. And I didn't exactly mention this, but the food peristalsis is very slow and very like a slow mixing and churning like this. And it's really just meant to sort of show the food to the lining of the intestines so it has a chance, so our body has a chance to absorb nutrients. But this is like a
Yeah.
so we use quite a propulsive,
Cleaning.
contractive. Yeah, it's sweep.
Yeah.
So we need to have, this conduction and these muscles to be able to do it. And so basically any diseases or drugs or injury, like surgery or accident or something, that could affect muscles and nerves can be a risk factor. But if we really dial down and look at like what are our SIBO risk factors that we know are slowing the migrating motor complex, the number one most common is food poisoning. And we can get into describing this, but before I do, I'll just list a few others.
Yes,
And
yes.
I wrote a little list here. So food
You got
poisoning.
to. Yeah.
Yeah, because there's so many, right?
It really is.
For medicines, and that's like food poisoning is like an acute disease, right? It's not a long term, it's a short term thing. But for medicines, that would be like opiate, narcotic, painkillers. We know that those can cause constipation, and they also can slow the migrating motor complex. Another thing is actually antibiotics. Now, we sometimes use antibiotics to treat SIBO, and there are certain ones that are helpful. But it's interesting, there was a pilot study done, so it's not been fully confirmed, on some antibiotics that aren't the most common that we use, but still, that showed that it slowed stomach motility. And there's a migrating motor complex that starts in the stomach. So that would be able to lead to SIBO. And clinically, we saw many patients reporting that they really felt that they got their SIBO after antibiotics for something else, some other reason. So that's another one. And another one that we need to think about these days are the GLP-1 GIP agonists. So these are Ozempic, Mounjaro, retatrutide, all of those. We don't have actual study information on this yet. However, we know that part of the way they work is to slow stomach motility. So we could imagine that this could be a potential risk factor. We don't know this yet, but we're imagining, right?
Yeah.
There's actually some Dr. Pimentel in the interview I did. Dr. Pimentel's our lead researcher on SIBO.
Yeah, and he's the best.
On an interview I can't remember when, within the last year, he actually said it's possible there's a way in which they could help. So we don't want to jump to conclusions fully yet. Okay, then back to the diseases that can potentially slow the migrating motor complex. Diabetes can create nerve damage, and we know a large proportion of people with diabetes within first 5 years of getting it will have gastroparesis, slow stomach emptying. And then this can lead to also small intestine motility issues. Hypothyroid, we know many people with hypothyroid have constipation. This also affects the migrating motor complex. Ehlers-Danlos syndrome. This is, many people may not know about this, but this is not a rare condition, actually. And we're trying to educate more and more people about it. It's a connective tissue disorder. It's highly linked with causing IBS, which turns out to be SIBO in most of these people. It can slow motility. Parasites, we don't yet know the exact mechanism, but we believe there's some parasitic infections that can slow migrating motor complex. Systemic sclerosis, also called scleroderma, that is a rare condition, but I see a lot of people with SIBO with it because it pretty much leads to that. Also, what that does, it's interesting to think about, it basically scars the intestinal tract. So the muscles, they're not supple and they can't do their contractions. They become fibrosed. So these are just, it helps to think, how is this happening? It's either nerve damage or muscle damage. Traumatic brain injury, which is considered to be like an epidemic. You don't need to have hit your head to have a traumatic brain injury. It's really about the brain moving within the skull. It can happen from slow moving things and falls and injuries. That seems to be, there's a possible genetic component where it's going to create secondary effects down in the gut for a lot of people. And that might be dependent upon genetics, but for many people, traumatic brain injury leads to slow migrating motor complex. And another one is Parkinson's. Parkinson's disease, one of the first symptoms of it is gastrointestinal. and constipation, and it
Yeah.
slows motility both in the large and small intestine. And just two more I'll mention would be like Lyme disease and all the co-infections. And
Yep.
many people feel like Lyme disease is maybe not that common, but what is much more common, I mean, I think it's a mistake to think that.
Yes.
What's much more common are the co-infections, which people, so many colleagues who deal with this disease, they always want to rename Lyme because Lyme, I think a lot of people go, and they
Yes.
push it out of their heads. So I've been hearing people wanting to call it chronic parasitic infection, the co-infections that come with Lyme. So very interesting. These are
Mm.
even maybe more common. Again, slowing the migrating motor complex. And the last one I want to mention is mold illness. This has just been a huge learning for so many of us, also considered to be like an epidemic
Yep.
because so many buildings and or cars have water damage that can lead to mold,
Yep.
even in warm environments. So just so long as any kind of moisture can get in there and it doesn't dry quick enough, right?
Yep.
And mold has many ways it can affect people, but one is, we think, slowing the migrating motor complex. So those are our risk factors in a nutshell. And it's a very broad amount of things, medicines and of course, then there's injury. Surgery. We see many people with surgery where maybe there was a mistake where something was cut or affected, nerve or muscle.
So you have just listed umpteen hundred different things, but this is, I think, it's important to list them because this is why we're talking about the complexities of SIBO and the complexities of the migrating motor complex is because, the diagnosis and the testing of SIBO, that's still very much kind of like the tip of where we need to be thinking. We need to be asking this question, why, and then why, and then why. And you can see that it just completely branches out in terms of all the different things that we need to be considering and working with. Like, this is a complex issue. I think that's what we're trying to really get our listeners to know, because I think when it comes to, and we'll get onto treatment, we want to be really clear about our different expectations and what's involved, because it's not as simple as take this and you're all good to go. Like there can be a lot more thing, especially if there's long-term management of conditions like diabetes or thyroid or TBI or things like that.
And also, I feel like what that list sort of exemplifies is sort of why SIBO is so common, why
Mm,
IBS, SIBO is, IBS is the most common disorder of GI, gastrointestinal disorder worldwide.
yeah.
And SIBO is the main cause of it. And this explains that. It's
Yeah.
like there's this myriad of ways people can get SIBO. And food poisoning in and of itself, the most common, could almost account for all of it because everybody's had food poisoning. However, not all types of food poisoning necessarily lead to SIBO. It's the bacterial type.
Mm,
Most food poisoning events are viral,
yeah.
and that isn't thought to lead to SIBO per se at this time. But still, so it's just like, no wonder it's so common.
Yeah. Oh, and like food poisoning, I know that again, like everyone's trying to avoid it, but even things like just like reheating your food, how you're cooking your food, like just there's so many things which it's like we have to be. I know that I'm very like my lens is always looking for, has that food been reheated? Have we treated it properly? Let alone different food vendors, which you can't control. But there's lots of things where it's like we need to take how we are heating and reheating and cooking food seriously, because it can lead to issues where you don't want to go there if you can prevent it in any way, shape, or form. I wanted to actually mention before, because people probably dying to know, how do we test for the migrating motor complex? But I wanted to ask before then, is there a link between the migrating motor complex and the vagus nerve?
Yeah. So the link is that the vagus nerve is thought to be very important in, I guess, initiating the migrating motor complex that starts in the stomach. So there's sort of like two migrating motor complexes, one that starts in the stomach
Mhm.
and then travels through the small intestine. And then there's one that starts in the small intestine itself. And the one that starts in the stomach, the vagus nerve is very important to that.
Mm.
And this isn't for sure, but in my readings, it looks as though the migrating motor complex that starts in the stomach might be the more important migrating motor complex, maybe the stronger of the two, and the one that maybe has more sway. So therefore, the vagus nerve is a very important part then of preventing SIBO because we need to have this migrating motor complex. However, the migrating motor complex that starts in the small intestine is vaguely independent, and the mechanisms for that are still under question and in theory, and
Yes.
complex, very
Yeah.
complex. But they know that if there's somebody that doesn't even have a vagus nerve, that they can still have the migrating motor complex that starts in the small intestine. It's just that, so we have a backup system. There's
Yeah.
redundancy, thankfully. So if there are issues with the vagus nerve, we still can have migrating motor complexes. But I think the one that starts in the stomach, from my readings, seems to be more important.
Cool. That's good to clear up because I know that, when we're thinking about nerves and the gut, again, we can be like all nerves. And I think what we're just saying is that, things are speaking to each other, things are working different ways. It's not necessarily black and white. There's lots of, connections that we need to be, I guess, exploring and still, we still need to learn and understand exactly how things work. So how do we test for the migrating motor complex?
Well, it's not easy. This is not like getting a SIBO test.
No.
This is not like that at all. The main test is called antroduodenal manometry,
Mm.
and it's done in a specialty GI center. You would most likely have to travel for it unless you live in a city where they do it at a hospital or something.
Mm.
And it's usually mostly motility centers that do it, like Dr. Pimentel's center or like some John Hopkins places and things like that in the US. But what this is basically some probes are put down like when you have an endoscopy, there's a tube that gets put down,
Yeah.
and it's put into the small intestine. And so that is something that happens. And then they can measure the pressure so that they can tell when these waves are happening. And it's overdone like 6 hours or something like that, so that they can see how many waves are occurring within a given amount of time. There should be a certain amount. And also it's a functional test, because then at the end, they can give a little bit of a prokinetic in this case. And I know we're going to talk about those. In this case, erythromycin, which many people may be familiar with as an antibiotic, but in low dose, it works as a prokinetic. And just briefly, a prokinetic is something that stimulates the migrating motor complex. And so they give this and they want to see, can the person's migrating motor complex respond to a prokinetic?
Yeah.
And interestingly, from chatting with Dr. Pimentel, he said, at least at the last time I had spoken to him about this, everybody he ever gave it to could. So the prokinetic stimulus worked to stimulate a migrating motor complex, even if on their own they weren't really having much of any. So that's interesting. It just shows how prokinetics can really help. So that's the test, and it's not easy to come by, but there's another test that we can do that indirectly in one scenario can tell us about the migrating motor complex, and that is IBS Smart or IBS Check test. It's basically kind of like we call it the IBS antibody test. Basically, it's checking for the food poisoning cause of SIBO. So it would only be valid if a person had their SIBO from food poisoning, and if this test was positive. But if this test was positive, and I know we haven't gone into that whole pathophysiology, but the mechanism by which somebody gets SIBO from food poisoning includes deficiency of the migrating motor complex. And so if this particular test is positive, we know that they have a deficient migrating motor complex.
Yeah.
And we also know that they got their SIBO from food poisoning. So this is a very valuable test as an underlying cause test, both for, the sort of the cause and the physiologic underlying cause. So, I love to run this test on people. And again, that's IBS Smart is the most like updated version of it.
Yeah.
And Dr. Pimentel created that. And it's a blood test. It checks for autoantibodies, actually. So that's the only two tests I know of. And I'm telling you, ever since I first got into this field, we've been desperate for an actual test for the migrating motor complex that we could all use. Some have sort of come up like they were going to happen, but then they didn't come to market. I know that sort of thing takes a lot of money and, studies behind it. So we're still waiting.
Oh, and that's important for people to know as well, that we kind of are flying blind isn't correct, but we're flying somewhat, trying to figure it out without having the specifics, unlike a SIBO test and unlike some of our newer versions of stool testing. Like, this is something where we can't really work to necessarily specific data unless you are fortunate enough to have the first test. And in Australia, actually, the IBS Smart test was taken. We used to have that here in Australia, but I think it was in 2022 for some reason became unavailable. So yeah, I know, right? So if I have any international patients, I'm definitely saying like, we can do this. But for the Australian patients, not so easy at this stage. And even working with those specialist motility clinics, again, like I think for things like maybe looking into gastroparesis, that's something that people are looking like, I have had patients with that data about their motility, but for a lot of my SIBO patients, like I don't know if that would ever happen for them in terms of their ability to get there and get that
It's not
result.
that practical, really. I mean,
Yeah.
because I was a specialist and only treated SIBO and was
Mm.
seeing really complicated cases, and people were motivated to want as many tests they could. I sent a bunch of people for antroduodenal manometry, and it was very illuminating, but it is not practical for most people.
Yeah. No,
Oh, and
absolutely.
one other thing I
Mm.
wanted to mention is I have heard about a lab called CoLab that has told me, and I've gotten some confirmation of this from various people around the world, that they ship worldwide and they do have
Ooh.
IBS Smart. I also had not, so that's positive, but I have had also some people tell me their customer service isn't that great. So sorry if I'm sorry to say collab. I just, people do complain about things, so I did hear one complaint. So, but
Giving
anyway, it's a
it,
possibility.
look, I've written a note for myself to look into that and we'll see what comes of that. So thanks for sharing that. How do we start treating the migrating motor complex? You mentioned before prokinetics, so maybe start with that. Yeah, tell us a bit more about the prokinetic treatment
I mean,
factor.
that's the main thing we do for SIBO. Prokinetics are an essential part of treatment because most people's underlying cause here is deficient migrating motor complex. So prokinetics stimulate the migrating motor complex, and we have pharmaceutical options and natural options. So I
Mm.
mentioned erythromycin. We also have prucalopride. That's a really excellent prokinetic. We also have low-dose naltrexone. There are other prescription prokinetics, but many of them have a lot of side effects or safety issues. So we usually stick to those. Domperidone is another one. It has had some safety issues, but those have been sort of re-questioned in recent years. It can cause some problems with people with pre-existing heart conditions.
Mm.
So that's just one thing maybe you'd need to rule out before using it. But I wanted to mention it because around the world, it's in widespread use very effectively. Prucalopride is just probably our best option because it has the least safety concerns.
Yeah.
And I'm mentioning this because many people who are familiar with prokinetics, prescription prokinetics, anyone who's in the medical field, they think of them as an unsafe category. And it
Mm.
isn't true. Many of them have safety concerns or side effects, but there are some that don't. And we use the ones that don't.
Yeah.
So then for the natural options, ginger root is really one of our main things. And we now have all of these formulations by various companies with ginger root that are meant to be prokinetics. There's like 6 or 7 different options now, which is amazing.
Yeah.
And we also use iberogast. Iberogast is what used to be a 9-herb liquid. Now it's a 6-herb liquid that had
Mm.
been in use for like 35 years and had studies head to head against pharmaceutical prokinetics showing it worked well as a prokinetic.
Yeah.
So that's a wonderful product. And there are now some like dupe formulas that are very similar to iberogast that are on the market as well, like IBS Shield and things like that.
Yeah.
And then there's a newer one on the market that uses bitter orange
Yes.
as its base. Bitter orange has had a lot of studies for prokinetic effects in like animal studies.
Mm.
So those are our main options for prokinetics. And really, you're really not meant to treat SIBO without using a prokinetic
Mm.
because so many people have this deficient migrating motor complex. Unless you for sure know that it's fine and the real issue is like a physical blockage,
Yeah.
then you
Which,
may not need.
yeah, which I guess what we're also saying is like it's sometimes hard to be 100% certain that it's not a problem because of just
Yeah.
the lack. Yeah, like it's hard to be like I'm totally migrating motor complex is working at 100%. So it can, I guess, given what we know about it, we probably tend to be prescribing that
Oh, yeah.
with the idea that it's likely that it's the problem. So with, I guess, the different options, I refer if I think people need medication, but definitely those natural options are my bread and butter. Is there a better or worse option, or is it that people respond to things differently? Because I think sometimes think, well, if there's medication, it's automatically better. Is there anything to say that that is the case, or is it again a bit like whatever works for you works for you?
I think it's both.
Yep.
Okay, so on the one hand, when I've seen very challenging cases, people with, really stubborn, difficult underlying causes where they relapse really frequently. And one of the main things we're doing here with a prokinetic is trying to prolong the remission periods. One thing we haven't talked about is that SIBO is a condition that has a high relapse rate.
Mhm.
And that is primarily because an underlying cause is still present, continuing to cause it. And while we always want to, as you mentioned, we always want to try and find these and try to work on them and eliminate them, there are many of the underlying causes that are chronic with no known cure at this time.
Yeah.
So like the food poisoning type and like, for instance, diabetes and things like that. So this can really help extend the remission period. Okay, so in cases where they relapse frequently, what we have found clinically is that the pharmaceutical options are likely going to be needed,
Mm.
that the natural options are not strong enough for
Yeah.
very difficult cases.
Yeah.
Okay, so there's that as a truth. Now, also, what is true is that for some people, natural options work beautifully for them, particularly if you're not talking about the most extreme, tough,
Yeah.
serious cases. For so many people, there is no need to go to a pharmaceutical. And it is just a matter of matching, just finding the right match for the person. And
Mm.
I like LDN in particular, low dose naltrexone, isn't actually a prokinetic. It's
Mm.
not classed in that category, but it has prokinetic effects proven by studies. So one could say that might even be the weakest, right, of all of them. But I have had patients who that completely did the job.
That's the
And,
thing.
so that's the thing where if you just find the right clinical match,
Yeah.
and I find they're all generally equal to start with.
Yeah.
You just start with whatever you want and then you just see how it goes.
Yeah.
But for challenging cases, we will often use morning and night dosing. The typical dosing is at
Mm.
night before bed because we're trying to stimulate the migrating motor complex while a person's fasting during sleeping.
Yes.
And migrating motor complex does a lot of its work overnight. So that's a typical thing. But in very challenging cases, we'll add a dose in the morning upon awakening.
Mm.
It could be the same one, or very often we'll use two different ones. And that's because prokinetics all have different mechanisms of action from each other. There's
Mm.
like 11 different mechanisms of action for prokinetics in what receptors they stimulate. They're a
Yeah.
very wide array of ways they work. And so if we use two different ones, we are sort of maximizing the effect. But that is only necessary when you start getting into more challenging cases. It's just, that's mostly what I saw. So
Yeah.
I had most people on two, I'd
Yeah.
say.
Oh, and look, that for people needs to be known as well. I think, kind of clearing up, the prescription versus the natural options is important because I guess when we're talking about access to these medication types, if we're talking about issues with even the acknowledgement of SIBO, let alone a motility issue, you might be laughed out of the office. So it's more like, okay, well, what can we do in the meantime as we are trying to maybe work with a practitioner who can prescribe? And that is, of course, if you're working with someone like me, a naturopath in Australia that doesn't have those prescriptive abilities, it's like, how do we hold the fort while you get the support that you might need if that's what it's kind of looking like we need to do?
Well, and also let's hear from your experience because as you said, these are your bread and butter. So, and I'm getting the sense like you find these to be incredibly effective. So that's very important.
Yeah, absolutely. Like, oh, ginger, my favorite little gingy. I just think it's amazing. And it's, people eat it and drink it. And, if we just dose it in a slightly higher and specific time of day. And if I say to people, hey, as a bit of a long-term support, just take 2 tablets of ginger at night or whatever the dose equates to be, they're like, yeah, it's easy. Like these are really kind of easy, sustainable things, generally quite cheap. Iberogast, as you mentioned, that reformulation. I know there are herbal, we can now make it herbally in that original formula. I don't know if that's it. I'm assuming it's the same because it is the same herbs, but again, just because there's that change in formulation. But I've been finding that the herbals work as long as you take them. However, sometimes they don't work, but I think that more kind of suggests that there's something more complex at play, which we need to be working on, or there's, they're not responding. And that's just part of it, is a bit of a try and see.
Mhm.
But I did want to ask you, because there is, I don't know if the word's confusion, that might maybe just be different lines of thinking about when to use your your prokinetics in relation to the treatment of SIBO. Can you use them at the same time? Does it have to be after? I feel like I kind of take it case by case in terms of when I use it. So what are your thoughts on in terms of that in relation to SIBO treatment?
Yeah, it can always be a little confusing because
Yeah.
basically when we need to have them is when you're not on the antimicrobials. Like, so after you finish a treatment round and you're waiting to figure out if you need another one. So like between treatment rounds, and also when you're done treating SIBO and you're in your remission, that's the most appropriate time to take them.
Mm.
But you can absolutely continue to take them if you then go on another treatment round. It's just not absolutely necessary. Like when you really must be taking them is when you're off the antimicrobials. But we usually continue the prokinetic if somebody goes on another treatment round, because that's something else we didn't quite mention, but many cases will need more than one antimicrobial treatment round to get it gone.
Yeah.
Might need 2, 3, 4, whatever. So absolutely fine to continue it. If it's something that you had to order and isn't covered by insurance, I don't know how it works in Australia, and it's expensive for you, well, then you may want to just not take it during the antimicrobial because you save a little bit of money. You don't actually need it during that time. So you can or you cannot during antimicrobials. And that's, I think, what confuses people, because either way is fine.
Yeah.
But where you make sure to be on it is once that antimicrobial treatment has stopped.
There's also, I guess, is it theory that, or a risk that people are a bit cautious of, is taking prokinetics with the antimicrobials? Does it decrease the efficacy or the time in the small intestine that the treatment has to work if you're trying to move it along? Is that theory? Is that something that we're just making up?
That would be theory.
Yeah.
However, what we have to think about is that most of these people have slow migrating motor complex. So if we're taking a prokinetic, all it's doing is it trying to bring it back up to normal physiologic level.
Yeah.
So you're not going to then make it go past normal physiologic, go boom, 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 and then there's no time for something to work in the small intestine. So I could see the reasoning here.
Yeah.
But I don't have any concern. And I have not ever noticed clinically if someone continued their prokinetic in the next round. I've never noticed a pattern that oh, then now it's less effective. So I'm not concerned about that.
I think that's good, because I know that's something where practitioners are trying not to do ill by their patients by giving them something and then kind of making it redundant. So that makes total sense. It's already compromised migrating motor complex. So any support probably is going to make it the super complex. It's probably only going to make it normal
if we're lucky, back to normal.
Yeah. So I know that we've started talking about when to take it, and thank you so much for clearing that up. But how long do we need to take it for? Is it years, forever, a couple of months? What is it?
Okay, so for chronic people, meaning they have ongoing causes of SIBO that they can't quite get rid of. We talked about some of those already. Those people will be on it ongoing, chronically forever, and there's no issue with that. These are safe, and a person could also decide to stop it at any time. The only risk in doing that is a relapse.
Yep.
So, and it's very common for people to try stopping their prokinetic so they can see what happens. And that's a good experiment. How long do you hold without a prokinetic? You might be fine. It's a fine experiment to do. You might not. You might get a relapse, and then you'd have to treat that again. And then now you'll know.
Yeah.
There's also people in chronic situations where we have them, not take it every night. Maybe they take it every other night, 3 times a week, and they hold beautifully that way. But if they go to 2 times a week, they start to get a relapse. So if somebody has it chronically long term, we can do these experiments.
Yeah.
Now, before we necessarily know if somebody has a chronic case of SIBO, just in the beginning, the recommendation is about 3 months.
Yeah.
And the reason for that is because the most common time for relapse, at first, at least in the very beginning, when you haven't dialed everything in, is about 2.5 months.
Yeah.
And so this just gets people, 3 months gets them past that vulnerable time.
Yeah.
So about 3 months, and then you just decide, what you want to do after that. Would you like to continue it longer? Many practitioners will do it 6 months and then do a trial of discontinuation. Some people are like, no, I'd like to get off it right now. There are other people that just, they have a intuitive sense or feeling that they really like it and they don't want to get off of it. So, but I'd say 3 months minimum and ongoing for chronic cases.
I think, again, you've told us that there's not the way to do it. There's obviously good guidelines, but there's, I guess, a sense of intuitiveness in this as well. If you're that person that's experiencing symptoms of like, oh, I don't feel as good since I've dropped this dose, or, there is a sense of listening to your body to kind of give you that answer, or at least assist that answer as to how you dose, because it's not black and white for everybody that it's 3 months and you're done. How do we, I guess, no, one thing I want to clear up, which we haven't, is the difference between a laxative and prokinetic.
So important. So important. Okay, they're not the same thing. So a prokinetic's reason for being is to stimulate the migrating motor complex, whereas a laxative's definition is to stimulate a bowel movement. And that is not in the definition of a prokinetic. Now, a prokinetic could have a laxative effect, but let's remember that what are the two most common side effects of all medicines? Headache and diarrhea. So almost any medicine could have a laxative effect, right? It's like, depends on how well it melds with you. But that is not the intention. There is one prokinetic that at a higher dose has been studied and shown to have a laxative effect, and that is prucalopride. Prucalopride has different brand names in different countries, so that's why I'm just using the drug name.
I'm familiar with that one in Australia.
Yeah, I mean, just like for anybody listening, it's Motility in the US, but I think it's Resolor or Resitrans, other places, it's called different names places. But at 2 and 4 milligrams, it has it's been used for chronic constipation, but what we use it at is a 0.5 milligram. And so this is a really important point, because we talked about how one of the most common manifestations of SIBO is to have diarrhea, but we use prokinetics in all of these people because prokinetics are not laxatives and they are not stimulating bowel movements, unless, of course, that just happened to be a side effect for that particular person. I have to say that's not that common, though. I mean, I give prokinetics to every single SIBO patient. So if that was to happen, you can try lowering the dose of whatever prokinetic you're on to see if that makes a difference, or if it doesn't, switch to a different prokinetic. Might just be that particular one happen to have that effect in you, like how headaches can happen as a common side effect, for anything. So a really important point here, though, is that many people do confuse these, and including medical practitioners, even like gastroenterologists, which is like, I don't know why this is happening, but so they will actually prescribe laxatives, like a prescription laxative, or people will take a over-the-counter laxative thinking that it can stimulate the migrating motor complex, and they can't. Laxatives don't stimulate the migrating motor complex. That's in the small intestine. They stimulate mass motor movements in the large intestine, or other things in the large intestine to produce a bowel movement. So you can't use a laxative as a prokinetic. It won't be stimulating your migrating motor complex. Where people seem to get most confused about this are the prescription laxatives like Linzess and Trulance and Amitiza. And that's the one that a lot of gastroenterologists will also say, well, I'm giving you a prokinetic. No, nix a. It doesn't stimulate the migrating motor complex.
That is so important to know, because I guess, again, this goes back to the idea that bowel motions indicate motility in the small intestine and even in other places. Not true, that there is a difference. This is where we need to be working with people who are trained and understand how to prescribe appropriately with that. And there's not necessarily anything wrong with taking a laxative if there's constipation there, but it's about understanding that you need probably the prokinetic as well.
Absolutely. Yeah. Almost like pretty much all SIBO patients who have constipation, while they're dealing with their SIBO and their constipation, we put them on a laxative. And my favorite is magnesium.
Ditto.
I'm just over the counter. I like magnesium oxide best.
Yep.
People have their favorites. And then they're on a prokinetic because magnesium doesn't stimulate the migrating motor complex. Neither does vitamin C or senna or cascara or
Yeah.
Dulcolax, stool. None of them stimulate the migrating motor complex.
Yeah, I'm a fan of magnesium as well. Oxide or citrate if the people on the oxide are like, too much,
Yeah.
too much. Again,
Yes.
this is just, again, finding the right fit for you. I think that's always going to be the take home with what we talk about is that there's no hard and fast rules. It can often be a bit of a trial process for each other. So I feel like that's just been a masterclass in prokinetics. Can we talk about fasting and how that can be, I guess, used as, I say, treatment or more of a support for the migrating motor complex? So what is the role of fasting, how we eat our food? Does it, like talk to us about that?
Yeah, this is so wonderful. So, Dr. Pimentel first is the one that I know that started telling everyone to do meal spacing.
Hmm.
And that's basically just like not snacking between meals, giving some time between meals. And at first he said that that would be about 3 hours would be good, but now he said about 5 hours would be the most optimal.
Yeah.
And what it's doing is just giving a chance for the migrating motor complex to happen because normally it would happen in between meals in the day if we're not snacking. And this would include also drinking beverages that have calories. So, like you could have black tea, black coffee, water, seltzer, but he does also say that things like stevia, non-caloric sweeteners, do actually have a place where they bond in the stomach that indicates a meal is coming,
Ooh.
even though they themselves don't have calories.
Mm,
So that would also need to be avoided. So
yeah.
no artificial sweeteners, just like plain black tea, black coffee, or water would be all right. But so no eating and caloric beverages between meals. And so this is the way that it should be normally, really normally. If we didn't have such crazy, busy, stressful lives where everybody needed to drink coffee all the time,
Yeah.
to get through their day, is that we would eat three distinct meals.
Yeah.
And then we have that time for the migrating motor complex to happen. That is really how it's supposed to be. And then before bed, no eating about 2 hours before bed. And then, of course, when you sleep, then that gives the chance for the migrating motor complex. So if a person can't go 5 hours between meals because they're just too hungry, they have low blood sugar or something,
Yeah.
go as long as you can. Three would be great. If you can't just do what you can. Or maybe you can do something like maybe you need to eat your meals a little bit more often in the early part of the day, but then you can eat your dinner earlier and give a nice long break. But you want to optimize some time of fasting in your day as well as at night for migrating motor complex to do its job.
Yeah. And that makes sense. And I think, because we are often working with people who may have eating disorders and issues with malnutrition and things like that. So optimizing in a way that is not stressful because we know that
Yeah.
stress works against us. One of my favorite things to suggest to my patients is just to, as we said, like kind of give a slightly larger overnight fast. It doesn't mean that you have to start eating lunch at 2 p.m. the next day. It just means maybe having an earlier dinner by even like half an hour, do the same in the morning. And there isn't necessarily that kind of feeling that you get when someone says fast or, meal
Yeah.
space and things like that. So I think that's, yeah, I think like there's lots of ways to do it, that people can kind of try to find, different ways to
Yeah,
optimize
well,
that
I
work
mean,
with their diet. Yeah.
even 2 hours, even 2.5 hours, just the idea if somebody was used to sipping on coffee with milk or creamer or something and sugar, they're used to sipping on that, every 5 minutes.
Mm,
Just try to change that habit and
yeah.
give it 2 hours without that. Just even that. I have to say that clinically, the meal spacing, whatever amount you can institute in whatever way you can do it, makes a huge difference. Like
Mm,
people symptomatically really feel this one. This gives a big payoff.
yeah.
So like it really helps.
Yeah. Oh, look, and it's knowing that it's a free thing. It's more about how we live and what we do. People, I mean, like, gosh, I love a free hack because it is essentially about what we can do to sustain these results. That is more about lifestyle and living changes versus what can we take to help. So I think anything that we can do to optimize that is a great thing. I just wanted to touch on, I guess, that nerve regeneration or that nerve signaling issue that we have. Is that possible to heal that, or is that kind of the same as the prokinetic thing where it's 3 to 6 months? What do we know about nerve regeneration?
Definitely nerves can heal, absolutely. And depending upon what's gone on to hurt them, what the damage is, we know that they can heal within weeks,
Mm,
or it might take much longer.
mm,
I think the issue with SIBO is typically there are still underlying causes that are continuing to damage nerves.
yeah,
And so that's the issue, is can we identify and remove ongoing damage to nerves? Is that possible?
yeah.
But setting that aside, there's nerve healers that we can take. So interestingly, prucalopride is one of them. That a prokinetic we talked about, it
Mm,
has all of these beneficial side effects. And one of them is nerve regeneration, actually nerve protection and nerve regeneration. So prucalopride's got this big superstar.
yeah.
And Dr. Pimentel has told me that he has had some patients that who got their SIBO from food poisoning, and that is thought to cause ongoing nerve damage.
Yeah.
But what he saw over, say, about 10 years, they never got food poisoning again, and they were on prucalopride for like 10 years, and their SIBO seemed to go away, like actually be sort of cured. So that's amazing, because really that's an ongoing autoimmune damage situation. So somehow their autoimmunity healed. But this is something he reported to me. But we have some other options too, like lion's mane mushroom
Yep.
is able to help regenerate nerves, and acetyl L-carnitine, that's often used in diabetes to help with that nerve damage. And also we have homeopathic hypericum.
Mm,
So also is a nerve healer. So we can institute any of these along with, but just keep in mind, potentially we might be sort of working against ongoing damage. But that story from Dr. Pimentel should have been a story of ongoing damage that somehow prucalopride seemed to resolve.
love that. And I guess like
No.
there's different options out there as well. Again, the procrolopide, I can never say that. Doesn't matter how many times I try to. That obviously gets a few gold stars, but there are other options out there as well, that we can consider as well. And I even think about there's different formulations of Prokinetics out there that have combined with it the acetyl L-carnitine, which you can kind of understand why they're doing that. Because if you look at that thinking, oh, that's weird, I take it for, or I know of it in a diabetes or blood sugar space, you can kind of see that there's that nerve regeneration aspect to that as well. Um, so I want to end. So there's two last questions I want to ask you. So if somebody thinks that they have a migrating motor complex issue or just has an issue with motility, knows that they do, what can people start doing today, right now, to kind of help?
Well, I think meal spacing that we
Hmm.
just talked about, that's free, as you
Yep,
said, and
love
easy
that.
to do. And it will optimize your migrating motor complex. Add in a prokinetic. And as you said, there's all these, and we both said there's all these wonderful over-the-counter ones. So, like some names of the ones we have here are Motility Activator, Modal Pro, Procine. Do you have those same brands in Australia? Do you have any different ones?
Oh, look, we do. Some of them aren't TGA regulated, so we can't, which is I guess our governing body. So we can't necessarily prescribe them, but people can source them online. Not that I say to do that, but we do have our different prokinetics. But iberogast and ginger are a lot of our TGA, regulated and
Those are the
certified
ones that
products. Yeah,
anyone can access. Yeah, you
yeah,
could just get ginger root. Those ones I just mentioned have ginger root in them.
yep.
Iberogast is great. And then I don't know if you have this dupe, but here in the US on Amazon, we have IBS Shield, and it's just a replication of the 9-herb Iberogast formula.
I think we have it's IBS Smart or something like that. We do have one which is like a chemist. It's yeah, yeah. So love a
Yeah, so
dupe.
those bring those in and take them at night before bed.
Yeah.
Just follow the label, add that, do the meal spacing, and then I'd say probably check for SIBO, if
Yeah.
get which you can listen to the other episode to find out about how to test for that and check that. So those are the main things I would think about doing. Oh, and I didn't, one other thing I didn't mention
Sure.
is just general diet. We have all these fabulous SIBO diets that I'm sure you probably talked about in your other episode, but you could institute some form of a SIBO diet. And basically what that is, in very brief, is cutting down carbs
Hmm.
and more highly fermentable carbs. And there's, you can access free all of these different SIBO diets online. to
Yeah.
get a sense of what they are.
Yeah.
But just, maybe don't go crazy, because people can restrict too much if you don't know you need it, right? If
Yeah.
you don't know for sure, but just maybe cutting a little bit down on the carbs. Like just some of the most classic things would be garlic and onions, high fiber foods, a lot of raw foods, a lot of high fiber, and sprinkling, like, say, ground flaxseed on everything you're eating, if you're one of those types of people.
Yeah.
And I say that only because, I've had patients where they're like, you didn't tell me to stop sprinkling fiber on everything and eating salads. And I just, if I just maybe switch over to some more cooked food and things like that, some basic little tweaks would maybe help a little bit.
I think they're, again, great starting points. And obviously, this potty has told us that it's super complex, that you can absolutely get started with, some things today that you've mentioned. But the long game is probably going to need someone else in there to support you. But I guess from all of your experience, I guess this is the final question, everything that you've done with SIBO and motility over time, is there a number one piece of advice that you want everybody to know when it comes to SIBO motility issues?
Well, I think it would be just to know that there's hope, I think. Like I generally, even these very complex cases that I tend to see, which not everybody is, there's such hope. Like SIBO is a condition that responds very well to treatment. And so, like, maybe just find out if you have SIBO and know that the treatments that we use for it, we typically get 80 to 90% symptomatic relief, if not even greater, which is better than just about any other condition.
Yeah.
And even when it's really difficult, we can dial in various maintenance things to give people back a happy, healthy life. So I guess I think the main thing I'd want people to know is that there's hope, and that it's, while it might be bad news if you have a condition, the good news is this responds so well, and we have such a good success rate, even if it's chronic,
Yeah, absolutely.
And I think the other piece of advice I'd have is maybe don't waste time. Like, this information is now available, even free, on all these podcasts, and I've got an informational website, SIBOinfo.com. It's just there for education. By the way, I'm updating it. I can't wait till
Oh my
the
goodness.
Got
to announce that.
Update. But even for free, you can just find out the information you need. And the tests, in the US, you can even order the tests yourself.
Yep.
Australia don't too. Even need a doc. Yep. Okay. You don't even need a doc. So, the thing is that you can really prolong your suffering and waste a lot of time by not just handling it. Just get the test, do the treatments, and start feeling better.
Yeah. Oh, look, I love that. Probably couldn't end it on a better, I'm like nodding my head saying that is solid advice, because all of those things is exactly why we do the podcast, is to give people hope where previously there hasn't been much. And that is such actionable information that people can start to get into right now. Like, now is the perfect time. We don't need to wait another month or 6 months to actually start chipping away at what they need to be, learning and testing about themselves to really figure out what's going on. So I think a message of hope plus everything else that you've mentioned, I think people are very lucky to have stumbled across this podcast today to hear you. So I will be putting in all of your links, and I will be looking out for that new updated website. I do frequent it because it's just, I'm looking out for new different things that you're adding on there, but I will put that down there in the show notes for people to contact. Dr. Allison, this was just the most amazing chat. And as I said, the fangirl in me is still fangirling that I've been able to chat to you for a whole hour about motility. This is just, made my day, really, made my year. So thank you so much for carving out the time to speak with me.
Thank you so much for having me. It's just such a pleasure.
Thanks for tuning into Gutsy Talks. I hope today's episode left you feeling inspired to take the next step in your gut health journey. If you're ready to dive deeper, head over to rachellarson.com.au. There's a range of courses and resources waiting for you. If you loved this episode, I'd be so grateful if you shared it with others who might benefit from this information. And so you don't miss out on future Gutsy Talks, be sure to hit follow and leave a review. I'd love to hear your feedback. I'm Rachel Larson, and I can't wait to connect with you again for our next Gutsy Talk.